Welcome to the talk on pain in the elderly. This is not the same thing as treating an adult. This is not the same thing as treating a child or somebody that's young that has pain. In anesthetics, some of us think that looking after a child is the same thing as looking after a small adult, and that is completely wrong. I understand that. We all get to a point where we think that, and then hopefully we grow and change our thinking. It's the same thing as looking after pain or managing an elderly person, whether it be pain, anesthetics, medicine, whatever it might be. They are different, they need to be considered different, they need to be assessed differently, and they need to be treated differently. So this goes through a couple of the principles. So this is the way we're going to define it. We're going to look a little bit about epidemiology and why pain in the elderly is so important, or becoming so important, or will become even more important. We're going to define what it is to be old or elderly. We're going to look at changes that occur in the elderly. We're going to reinforce a couple of those. We're going to consider some clinical implications, consider cognitive impairment as a topic by itself to stress its importance, and then principles of assessment and management. So the epidemiology, a lot of papers out there on epidemiology, a lot of papers, good reviews on pain management in the elderly, all focusing on a number of important points. So let's look at this. This is the worldwide population of those over 65 years old. Now, I'm not saying that 65 years old means you're elderly old, and we'll come to that, but nevertheless, we'll use that as a number. In 2008, and this is in millions, in 2008 we probably got about 300 million, 300 to 500, I beg your pardon, 500 million adults over 65 years old, or those over 65 years old worldwide. If you look at those numbers in 2040, which is not that far away into the future, over 1 billion, so that's 1.3 billion people are predicted to be over 65 years old. That is a huge jump. These people are going to have musculoskeletal problems. These people are going to have cancer and cancer pain treatments. These people are going to have pain. It's going to be a huge problem. We're also working older, so pain is even more important. So now let's look at a couple of numbers from the USA. I think it was the census in 2008. So the USA at that point had about 303 million people. Those over 65 in 2008 in the United States, 38.9 million. So that's 13% roughly of the population. That's a big number. At the same time, if you have a look at those over 85, it amounts to about 5.7 million, so 2% of the population. Again, not an inconsequential number. The older you get, the more pain you get, and we'll talk about that in a little while. So, now let's predict what's going to happen in 2050 in the US. 17.1 million people over 80 years old, and that's over 80, so this is not over 65. The number's going to be huge, and that's now gone from 2% of the population in 2008. That was more than 85, so there was a 5-year discrepancy, but to 6%, so that's almost tripled really. That's a huge number. So the prevalence of pain, all I want you to know about the prevalence of pain is it steadily increases with age. That's it. That's all you need to know. The older you get, the more likely you are to feel pain, and the more pain you will feel. So let's ask ourselves what we define as old. Is old having grey hair? Is old retiring from work? Is old getting wrinkles? Is old having grandchildren? Is old just feeling old? How are we going to use the word old, or how are we going to define the word old? And a similar thing, what is young? Is young having a superbly ripped body? Is young having young looking muscles? What is young and what is old? And there you can see, well, this guy just throws everything out And he's old chronologically, but he certainly doesn't look old, and he's probably younger than most physically. So generally speaking, 60-65 is a cutoff, but it is, again, not everything. In the developed world, we use chronology or chronological age generally to define age as 60-65, whereas in Africa, in the developing world, being elder is more about your status in the culture, in the community. And that status, you could be considered elder anything over about 50 years old. So again, have a definition of age, or understand that it's difficult to define being old and elderly. So the changes that occur in the elderly, the bottom line is that the physiological reserves are reduced or diminished, or diminishes as time goes on. So the older you get, the less reserve you have, the less ability you have to deal with problems. So you just haven't got that reserve as you get older. And that's the main change that occurs in elderly, if you really want to break it down. So the things that happen, well, as you can see, they're biological things that happen and that you need to consider if talking about changes in the elderly. There are psychological things that you need to consider and social things that you need to consider. So I'm not going to spend any time talking about psychological and social changes that occur in the elderly. Just before we get onto physiological and perception changes, it's important to remember that there's coexisting diseases and there's significant multiple coexisting diseases. And the same thing goes about medication. Significant multiple coexisting medication, polypharmacy. A lot of these patients are more than 5 drugs, and these are not small drugs. They're not clean drugs. They've got a lot of complex interactions that can occur. But let's briefly mention the physiological changes that occur as one gets older. So the physiological changes that are occurring in me compared to 10 years ago. The brain, the heart, the liver, kidneys, kidney function, neurons, interneurons, neuron function, skeletal function. It all reduces in size, it all reduces in capacity, brain function reduces, cardiac output reduces, blood flow to the liver reduces, enzyme function reduces, kidney function reduces with age, creatinine function, GFR, glomerular filtration rate changes. Nerve fibers don't regenerate as much. The nerve fibers break down. They lose myelin sheaths. Receptors change. Neurotransmitter density changes as well. Skeletal function atrophies as time goes on. So these are the physiological changes that occur. And this has implications on managing pain. And of course they can directly cause pain as well. So you lose your skeletal function, you use a range of movement, of course your joints get stiffer, your synovial fluid doesn't replenish, you lose cartilage, you get painful musculoskeletal problems. Okay. So what these physiological changes means is that they're going to have pharmacokinetic, pharmacodynamic changes that occur in the elderly, and they're complicated, and we don't have to know all of them, but it's important to know that hepatic metabolism reduces, drug clearance, kidney drug clearance reduces, and that has direct implications on a number of medications that we use, particularly the opioids. Reduced renal clearance, again, of some drugs, particularly the opioids. And then there's increased apparent CNS sensitivity to drugs, again, particularly the opioids. And the bottom line is, and this is a great strategy for anyone you deal with, start low, go slow. Really take your time. And this doesn't only pertain to pain and pain management, but think about giving an anesthetic as well. Start with a smaller dose. If you think that's what you're going to use a smaller dose. And if you think that's how long you need to wait for effects to occur, wait so much longer. Start low, go slow. And then, of course, the elderly have different pain and pain-related conditions, so they've got different kinds of acute pain, different kinds of chronic pain, ischemic heart disease, peripheral vascular disease. I very rarely see somebody that's young with peripheral vascular disease. They generally tend to be older, have coexisting medical problems, diabetic, smoker, have coexisting medications and complicated medication interactions. Remember zoster, postherpetic neuralgia as well, so that's a chronic pain condition, but zoster is the acute side of it. And then the chronic pain conditions of musculoskeletal cancers. As I've mentioned, the older we get, the more we're likely we're going to have cancer and musculoskeletal pain. And then the neuralgias that occur in elderly people, the herpetic neuralgias, the trigeminal neuralgias, and of course the diabetic peripheral neuropathies. I have to say I don't see a lot of diabetic peripheral neuropathies in my clinic, and that might be because they're managed elsewhere by physicians. Okay, that's painful diabetic neuropathies. Now, changes in pain perception. I'm going to just spend a couple of slides talking about this because it is so important. And the more I read up on pain in the elderly, the more I understand about pain perception and how it changes. Commonly through my training, I was taught that patients that are elderly don't feel pain. Well, that's not true in a sense. It might be true in a sense, but it is don't take that as gospel. That is not true. Our pain perception might change as we get older, but we do feel pain, and we still suffer from the side effects of pain or the consequences of pain. So Gibson's done a number of papers, and there's another one, Clinical Update, looking at neurophysiology of nociception. Really good papers out there. And I wanted to break down changes in pain perception to 4 kind of headings. Changes in the primary afferent fibers, yes, first order neurons. Changes in the central nervous system, yes, from the dorsal horn upwards. Changes in the pain inhibition, so top-down control of pain changes, and then change in nociceptive pain thresholds. You can probably consider this under primary afferent fibers. But anyway, primary afferent fibers, so first order neurons, sensory fibers, the density changes. The fibers become damaged and degenerate. The conduction velocity changes. There are changes in substance P, CGRP. There are changes in heat sensitivity as well. So a number of changes that occur that change the way patients perceive pain. The CNS undergoes remarkable changes, age-related changes as patients get older. The same thing happens in the CNS that happens in the periphery. So density, damage, conduction velocity, CGRP, substance P, heat sensitivity, all that changes centrally as well. Myelin is lost, axons involute and change and break down. There's reductions in levels of noradrenaline and noradrenaline function, serotonin function. There's general size reduction in the pain matrix. Now looking at fMRIs, there are various areas in the brain that are considered the pain matrix, and they're not one structure, it's more substrate. So the S1, S2, anterior cingulate cortex, insular prefrontal cortex, hypothalamus, so various aspects of the pain matrix change. Neurotransmitters change, dopamine, gabapentin, endogenous opioids change, catecholamines, as I've mentioned. And all these things you might say, well, then patients should feel less pain, and it might be the case, but just because they feel less pain doesn't mean we shouldn't be treating them. It doesn't mean that if we don't treat them, that pain wouldn't set up lasting changes, and that's the key, which we'll come to. But they've got less pain inhibition, so they may to a point feel less pain or perceive less pain, but they don't have that control. And their thresholds are certainly not that they feel less pain. They have lower pain perceptions and lower temporal thresholds, so their thresholds are lower. So they do perceive that pain earlier on, and this is done with some really good experiments. The key is, and that's outlined in red, that when they get hyperalgesia, when they get secondary hyperalgesia, looking at studies where with capsaicin applied locally, comparing young to old people, or elderly people, should I say. I have to be politically correct. So when they get hyperalgesia, certainly in experimental paradigms, that hyperalgesia takes so much longer to resolve as you get older, and that's important. And of course, because the nervous system changes, there also something called silent pain that some people can have. So they can have MIs, they can have peritonitis, where the pain doesn't present as the pain that you would expect. It's not as painful pain, if that makes sense. So it's important to understand that there are changes in pain perception, and it doesn't mean they feel less pain, because it still happens, it still occurs. They don't have inhibition, and they've got higher thresholds as well. So great paper, and let's see how they put it. And this is how Gibson and Farrell put it. I'll just let you read that. It's so true. This shouldn't happen. So this is the implications that the changes that occur in the elderly have, and I've just separated in a couple of little blocks just to make it a bit easier to comprehend. They get more diseases, they get more treatments, they get more surgical diseases, surgeries, more drug medications and interactions, so they get more of things. The pain, the changes make them more vulnerable to pain. That's the bottom line. They get more silent pain. They don't report pain as much. The pain that they get, as I said, is more silent. It's more atypical as well, so you might miss out if you're expecting textbook stuff to occur. And the pain intensity might be less, but that doesn't mean we shouldn't be treating them, and that's the key. We have to treat their pain. And when the pain occurs, there's more consequences of pain, and this is the crux of it all. That's why it's in the middle. They get more wind up, they get less tolerance, they get less plasticity, so they're less able to recover from it. They get more sensitive, and the sensitivity lasts longer as well. That's important. They've got more cognitive decline, so we don't assess them as much. It's difficult to assess their pain. They get less treatments and more side effects from the treatments because they're more susceptible to that. So really, there's a high risk of being more susceptible to severe pain. There's greater suffering and less quality of life from the pain. And there's a higher risk of developing persistent and chronic pain. That's important. So cognitive impairment, let's just spend a few moments thinking about cognitive impairment. If you've got cognitive impairment, pain complaints and pain intensity is inversely proportional to that. So as cognitive impairment goes up, pain intensity goes down, pain complaints go down. Yes. Does that mean they don't feel pain? No. We know that communication problems exist in those with cognitive impairment? Yes. Don't feel pain? Absolutely no. Absolutely wrong. They do feel pain. There is now proof that they feel pain as well. In fact, there's now even evidence looking at fMRIs, such as the example you've got on your screen, where they may even have higher pain or higher focusing of the brain on pain, or higher nociceptive pain. So it might even be that they feel more pain. Again, this is just one of many papers, but they do feel pain. And just a brief reminder that these patients are more at risk of post-operative cognitive dysfunction. Elderly, particularly if you're older, and particularly following surgery, non-cardiac surgery, or cardiac surgery for that matter. So assessment, bottom line, we know this, full, comprehensive, multidisciplinary, no rocket science behind this. There are barriers to assessing pain in the elderly, and if you're talking about assessment, you need to mention the barriers: the vision, hearing, language, culture, and of course cognitive function and decline. So consider the barriers when assessing pain. So pretty much like the pediatric pain assessment, it needs to be context appropriate, or needs to be individual appropriate. What's this individual about, and what are the issues, and that's going to change the way I assess this individual. Unidimensional tools can be useful. The verbal descriptive scale tends to be better used, or better understood, or better understood by patients, as opposed to the numerical rating scales or verbal numerical rating scales. So the unidimensional scales can be used, and they can even be used to a degree in those with cognitive decline. But observational tools are useful, particularly in those with cognitive dysfunction or inability to communicate. So these are observing behaviors and using it as a proxy really to define pain. Now the American Geriatric Society, it's a good paper, Management of Persistent Pain in Older Persons. What they did was they identified 6 key kind of areas of behavior that could signify pain. So facial expression, various different kinds of facial expression, pretty self-explanatory. Verbal and vocalizations, even just noisy breathing, calling out, chanting, those kinds of vocalizations. Body movements. There are a number of body movements that might signify pain. Changes in interpersonal reactions or interactions. Now this is important because even if a patient Remember, the pain presents itself differently. They may just become socially withdrawn. That could mean that they're in pain. So these are the subtle changes that occur that might signify pain. Subtle observational changes that occur. So changes in activity or patterns or routines, okay? And then mental status changes, crying, tears, confusion, irritability and distress. So these are the, as defined, or the domains defined by the American Geriatric Society, 6 domains that might allow observational assessment of elderly patients in pain. And then this review went on to look at pain assessment in non-verbal older adults with dementia. Non-verbal older adults with dementia, and there are a number out there, and this was just, I think, 10 or 11 that this paper looked at. Abbey Pain Scale assessment of discomfort in dementia, checklist of non-verbal pain indicators, discomfort in dementia of the Alzheimer's type, and a number of others. As you can see, there's the flack, faces, legs, activity, cry, consolability. That's been useful in pediatrics and validated in peds, but it needs to be validated and made reliable in older patients as well. So there are a number of tools, none of them gold standard assessment of pain in non-verbal older adults with dementia. The Dolo Plus might be useful. It's comprehensive, addresses many of the key indicators from the AGS, American Geriatric Society recommendations. It's been extensively tested in Europe, or so the website says, but there may be some translational issues. So Dolo Plus might be useful in this group of patients. And then the other one is the PAIN-AD, pain assessment in advanced dementia. Short, easy to use tool for this group of patients, non-verbal patients, but it's not comprehensive. One of the good things is it's got a 0 to 10 rating, which we all like, but the soundness of this hasn't been established for pain behavior. So there's no real correlation between pain behaviors and pain scores, and so that correlation hasn't really been established yet, although it does sound pretty good. So again, conceptually yes, but further work is needed before we can assess this group of patients well. So the management, looking at the AGS panel and that same paper, we're just going to briefly mention a few things, and there's nothing new here. This is all common sense. Remember non-pharmacological approaches, remember education. Remember, when you're dealing with pharmacological approaches, what is the compliance and how am I going to improve the compliance of medication, because that can be a big issue in this patient group. So compliance, communication can be a problem. Patients might not take them because of the side effects, so you not really need to think about this, and you need to find out what's going on and why the compliance is so poor, if it is poor. But even if it's not, you need to make sure that you've got high compliance. So from the start, communication, education, rationalize polypharmacy and simplify your drugs. Education, as I've mentioned, use medication cards, use dosage boxes, use whatever it takes to make it as simple and as clean as possible for these medications to be taken. Nothing new, and this paper makes mention of each one and makes some points on each class of medication. Just talking about the anti-inflammatories and coxibs, they mentioned the so-called triple whammy. Oh, sorry, this is not mentioned in this paper, but it's something I wanted to bring your attention to. So diuretics, anti-inflammatories, ACE inhibitors, and angiotensin receptor blockers. Triple whammy, as it's been mentioned in the paper, in one of the papers that you've got referenced. Diuretics, anti-inflammatories, ACE inhibitors, really consider whether you're going to use anti-inflammatories in this group, because they are at risk of developing complications, renal dysfunction, perhaps even renal failure. Now the opioids, nothing new. We must practice safe opioid prescribing wherever we do it, whenever we do it, because we know that chronic pain and opioids, we haven't got that correlation yet. It might be useful in a small group of patients. Excuse me. We don't know what the efficacy is long term. We know that there are side effects. So again, when you talk about opioids, you're always mentioning safe opioid prescribing. They mention methadone, and if you're going to use methadone, be aware of its uses and be very cautious with it. Remembering with opioids is interpatient variability. It changes between patients, so one thing doesn't mean it's going to work for two patients. Bottom line, start low, go slow. And always consider the side effects of opioids, because they're going to get them. If there's one group of patients that's going to get side effects, it's going to be the elderly. Adjuvants. Combinations enhance therapy, which makes sense, so use combination therapy. Start low, go slow. Gabapentinoids can be useful in this group because they're such relatively clean medications with little interactions, particularly with those that are on polypharmacy or multiple medications. And like anything, make sure they have an appropriate trial, appropriate dose for appropriate length of time before you say it doesn't work. Corticosteroids can be useful in this group, but again, be very careful. They can be used in inflammatory disorders, and that doesn't mean arthritis, not osteoarthritis, more the rheumatoid arthritis. But inflammatory disorders and metastatic bone pain, corticosteroids, use them. And then this paper pays particular attention to topical agents, so topical anti-inflammatories might be useful. Topical lidocaine for local small areas of neuropathic pain. In fact, they even say that there's weak evidence to support topical lidocaine for non-neuropathic localized pain areas because it's got such a good side effect profile. I just want to briefly mention interventional techniques. Consider them, use them in the elderly, because anything to stop the polypharmacy, to reduce polypharmacy, drug interactions, complications, cognitive dysfunction, because if you fill a patient up with sedatives, it's going to change their cognition, and they don't want that. So consider interventions, whether they be in the chronic setting or the acute setting. Remembering in the acute setting they may be more sensitive to regionals because they might have less clearance, less renal function of local anesthetic, so you might need low volumes. Hey, bottom line, start low, go slow. Thoracic epidurals can be particularly useful in this group of patients having big thoracic abdominal surgery. So that brings us to the end of this presentation.